And with this, we shall move on to the next session where learn from the master's session. We have Dr. Michael Krukoff from US, who is going to give a talk on evolution in treatment of calcified lesions. And we have our own master, Dr. Balbir Singh from Medanta Hospital, Guwahati, India, who does not require, both of them do not require any introduction. And I'm very sure that our masters shall help us to enrich our knowledge very well. And we have Dr. YVC Reddy and Dr. Kirti Punarmia in the expert panel. And to take us through this session, I welcome Dr. V.T. Shah and Dr. V. Sujata. Dr. V.T. Shah is a senior intervention cardiologist from Bombay. I have been seeing him for the last 20 years. So I used to meet him in conferences. And I have been, even now we meet him every day on web meetings. A very active person even at this age. And is an excellent operator in complex intervention, CTOs, ROTA, lithotripsy, and then always updated, always knowledge thirst. And we really appreciate him, Dr. V.T. Shah. And it's a pleasure having him here as our moderator. And we have Dr. V. Sujata, Senior Consultant Cardiologist from Indus Hospital, Visakhapatnam. She has close to 20 years of experience in complex intervention, intracoronary imaging, physiology, complex endovascular procedures, and she's an expert in all this field now. Now I request Dr. V.T. Shah and Dr. V. Sujata to take over the session and facilitate the Learn from the Masters session now. Over to you, sir.
Yeah, so good evening, everybody. Thanks, Dr. Selvamani, for this kind introduction and opportunity to interact with other experts in the field. And I hope that today we have a very good interactive session. So may I now request our guest speaker to please initiate his talk.
Dr. Krukoff, please.
Dr. Michelle Krukoff, can you unmute yourself?
Yes, can you hear me?
Yeah, we can hear you now, sir.
Okay, great. And I am going to share my screen. I think somebody has to unlock so I could share my screen. While that's going on, I will say my great deep gratitude to Dr. Selvamani and the organizing group for this fantastic meeting. It's so refreshing to reach out to our international colleagues and have contact again, as the pandemic has reduced us all to managing around this unending time frame, as it would seem. So okay, it looks like this may work. Let's try that. Can you see slides? Or I may have lost. Can you?
No, we can see the slides, sir. It's perfect.
Okay, and you can hear me okay. Okay.
Yeah, we can hear you fine.
Yeah. So I will join virtually. It breaks my heart to not be able to travel to India to see so many of my friends and so many of my teachers over the years in dealing with the very heavily calcified diffuse disease that is the nature of coronary disease in India. But as I think we talk about treating calcified lesions, we've learned a lot. We still have a lot to learn. But to me, it's very important, first and foremost, to have a clear strategy as to why we're going to do what we do, and then what we're going to do in steps, and try and keep this focus very clear, so we don't try doing too much, because calcified lesions can be very humbling when you go overboard in trying to manage them. So first and foremost, there has to be a clinical rationale, and here we know well that the clinical outcomes with PCI and calcific lesions actually are very troubling compared to non-calcified lesions. This is an 83-year-old male who I treated, presented with a non-ST elevation MI, had severe 3-vessel disease. He was taken off the table because he had reasonable distal vessels for CABG, but not simple. And because of his age, he really was not interested in open heart surgery. So his medications were greatly intensified. And despite that, 2 weeks later, he came back with a second non-ST elevation myocardial infarction. So this is just a fluoroshot, but you can see the diffuse calcification that comes with age, and many other of the comorbidities that we know are also very difficult to deal with: diabetes, renal dysfunction, etc. In this view, you can see in the middle of an ectatic area of the LAD, a tight lesion. There's a downstream lesion I'll show you further, and very diffuse disease in the circumflex out to a large marginal, as well as in the circ continuation, which is collateralizing a totally occluded right coronary artery. His ejection fraction was reasonably preserved. There was enough flow through all this. Here you can see the more downstream lesion in the LAD and the collaterals to the right a little bit better. So in our strategy, our approach is to try and get the hardest thing done first. And our feeling was the diffuse complex bifurcation in the circumflex with both the marginal and the collaterals to the right would be where we would start. The LAD lesions looked a little more discrete and potentially manageable. So we continued this as a promotion along that line, that if the circumflex went well, we might go ahead and continue with the LAD. At his age, his renal function was fairly well preserved. On the other hand, if the circumflex became very complex, used a lot of radiation and a lot of contrast, we would stage the LAD procedure. We worked from the right radial approach. We used a 6 French EBU4 guide catheter, a 14,000 Struma run-through wire, and at this time, the state of the art for us was the Xience Alpine drug-eluting stent. This was some years ago. So the run-through, of course, is an end-to-end nitinol-based wire, and was able to fairly easily primarily cross through into the marginal. Dilating with a plain balloon was not complex. There was very good guide support from this EBU4 catheter. And putting a stent down there, on the other hand, was a different story. So in fact, we were unable to advance a stent beyond where you see this one placed. So we put a stent here, first size. This is a 28 30 Alpine that we placed proximally with the hope that that would help us get distally, but it did not. So this is a guide liner that we walked over a balloon down through the proximal stent in order to finally be able to pass stent distally. And all in all, came forward with a reasonable result without having to convert it to a bifurcation lesion. There's obviously a tight lesion in the AV groove here, but the flow to the right coronary collaterals were unchanged. So having used actually only a modest amount of contrast to do this, we went ahead and decided to address at least the proximal LAD. And this is an NCU4 balloon in the proximal LAD, and you can see it's not dilated, even though we pegged the end deflator at about 30 atmospheres in trying to dilate. Again, this is sitting in the middle of an area of ectasia, which was not a primary target from our point of view, ideally for any sort of atherectomy. After the balloon attempt on here, you can see there's a dissection on both the proximal and distal edges of the lesion. And what we did was withdrew the wire and just waited for about 20 minutes and watched. The lesion was stable, the patient was stable. So we put him on ticagrelor and aspirin, watched him in the hospital overnight. He was fine, walking around comfortable, sent him home and scheduled him to come back after the dissections potentially had healed to do an atherectomy gently as possible. in the midst of that ectatic segment, and he died at home 2 days later. So this is the world of calcium, where I think we all probably have individual experiences we can share. Calcified lesions may be prone to dissection. They may interfere with our ability to restore a full lumen as we would like to see it. They may prevent adequate stent expansion, and they may play havoc with getting a stent even just to the lesion that we'd like to. And in a drug-eluting stent era, we have to realize that it's the surface of the stent that delivers drug, and if the surface is not evenly delivered, neither is the drug delivery. Furthermore, we have to recognize that in virtually every randomized ACS PCI study, pivotal DES PCI study, that patients with severe calcification are excluded. So we have very little clinical evidence actually on how these patients happen to behave. The most interesting experience I think that we have from an evidence base comes from Philippe Généreux, who ran the core laboratory for the CRF group during a series of prospective randomized trials, Horizons, Acuity. And these were trials, again, that excluded patients with heavy calcium by their inclusion-exclusion criteria. But that was a judgment made at the site. From the core laboratory point of view, almost a third of these patients had visible calcium or out to severe calcium. And when those patients were stratified by the calcification as seen in a quantitative core lab, the outcomes for everything, death, cardiac death, MI, TLR, stent thrombosis, are worse if there is significant calcium as quantified in a core laboratory. Okay, so understanding the why should we worry about calcium gets pretty close to home for any operator in a cath lab. How about detecting calcium? And here I think you have a lot of extremely elegant insight from operators, and a lot of the work that's been done in getting imaging capabilities out to centers for more routine use than we have previously seen. And here I think understanding that it matters to the outcomes as well as to planning the procedure, there is no question that it's fine if you see calcium by angiogram to be worried. But if you use intravascular imaging and either IVUS or OCT, sometimes the challenge is to get the imaging device through a diffusely calcified vessel so you can actually get an image. But there is no question that when you use intravascular imaging, you see calcium, even severe calcium, that is not visible on a simple angiogram. And that's particularly true in Western populations like the United States, where people are fat, because the gray scale that we use for angiography hides calcium when people have a lot of tissue. So intravascular imaging adds greatly to that. So what about treating calcific lesions? And you've just, I was privileged to hear some of the previous session, and there's no question that we all have tools that are not globally distributed. So I have some, you may not, you have some that I don't. And that's why I've loved going to India for so many years, is to learn. We always can learn from one another. But clearly, I think the most profound tool that in a simple sort of minded way of thinking, which is my way of thinking, the one tool that allows me to both debulk lesion mass with selective control and to change vessel compliance by debulking calcific mass is atherectomy. And specifically, the tool that has become for me the gold standard in this regard is the orbital atherectomy device, which at least we have in the US, distributed by Cardiovascular Systems Inc., or CSI. And having been a rotablator user since the roto was invented by David Oth, I think the big differences here are that this is an eccentrically placed cutting surface. And as it spins, the centrifugal force carries the cutting surface outward to the lumen. So there's no upsizing burrs. If you want to make a bigger lumen, you simply increase the speed of the device. The centrifugal force increases. That means that for operators like I am, who are pretty dedicated to radial procedures as a safer, better approach, this entire device does everything it can do through a 6 French guide quite easily. The other difference in this device, unlike a roto, is that this device, because it's eccentric differential sanding of a plaque, of a calcific plaque, it ablates tissue both when it's going forward and when it's pulling backward. And I'll show you an example of a difference that can make in actually using, rather than simply being subjected to the bias of the guide wire or the bias of the direction a rotablader will follow, which sometimes is around the plaque I want to debulk rather than into it. This device with bidirectional cutting, you can make a curve go up by pushing and then come down and flatten, pulling back, and create a much more generous ability to selectively and in a controlled fashion ablate tissue in a lot of calcific settings. So that's my tool of choice. So here is a case study to illustrate a little bit of that, and then I'll stop for purposes of time. This is a 71-year-old female diabetic. She was 6 years post-CABG. She presented to an outlying hospital here in the North Carolina community where I live and work. Excuse me. It's an hour earlier here than we thought it would be because we actually changed daylight savings time hours at 2 a.m. this morning. So I'm glad we woke up a little early. This lady presented to a hospital about 90 miles from our medical center with a non-STEMI and underwent catheterization on PCI. I'll show you. You can see the vein graft to the circumflex system is occluded. The vein graft to the right coronary artery is occluded. The mammary, this is not a great picture, but I think they sufficiently image that the mammary to the LAD is intact. And I think that we could impute the LAD is in reasonable shape. The native circumflex, you can see is diffusely calcified, but has a very discrete lesion before this very large marginal branch. And then the right coronary artery, you can see the calcium stem to stern, and we'll talk a little bit more about this as the case goes on. So what they did, these are the only two pictures that they conveyed. This is a balloon in the marginal near the proximal lesion. And then we usually take a final shot without the wire, but this is the only shot they have. But I think it looks like it's probably a pretty good result in the circumflex artery. Working from her right femoral artery that night, she bled into her leg, dropped her hemoglobin to 7.8, had angina. Her dual antiplatelet therapy was interrupted. She was transfused 6 units of packed red cells. She had recurrent angina even post-transfusion. Interestingly, an MI was ruled out, and it was not imputed that she had stent thrombosis, but she was transferred to Duke Medical Center. We approached her from the right radial artery, and as with some radial cases, there were some anomalies. This is a very tortuous right subclavian into the innominate. Fortunately, having done this quite a bit and learned quite a bit about doing this, in fact, from Dr. Patel and colleagues in Ahmedabad over the years, we solved this pretty simply with a woolly wire. The guide following the woolly has a big loop in it, and the trick here is to pull back with counterclockwise torque, which reduces the loop and gives us back control of what is an AL 0.75 6 French launcher guide catheter. The importance of getting it straight is so that we can then properly intubate the right coronary, and you can see here the AL 0.75 fits quite well. This was in our fairly early experience with the orbital atherectomy device. You can see we did put a pacemaker or temporary wire in for this right coronary. I don't think we would do that today. We tend to treat more with aminophylline if and when needed. But you can see from the guide catheter, we've got great support. And I'll show you now, this is a 90-degree left lateral picture of the right coronary. You can see the shadowing, you can see the calcium intrusion here. You can see the angulation of the lesion right here. And I just want to make the point that with that severe angulation and any sort of atherectomy device, concerns about perforation are very real. But what the orbital allows us to do, as I'll show you, is not just to do atherectomy going forward, but with a wire across and with the shaft of the device across to work from distal, pulling backward, which a rotablator, of course, won't do because there is no cutting surface on the backside of a roto. But with the orbital, by pulling backward, we can ablate tissue much more aggressively in a much more straightened area, because this is not actually a bend in the right coronary at all. This is a pseudo lesion bend. So this is just all plaque, and the track through the plaque is what's bent. So this is the run-through wire, again, that we use as a primary wire. Over that, we will bring down a microcatheter and exchange to the Viper wire, which is the 10 to 12 thousandths wire that is used for orbital atherectomy. Orbital is a slower speed than rotational. Roto, we usually go in at about 160,000. Orbital is 80,000 at low speed and 120 at high speed. And again, that's not for different cutting approaches. It's simply to make bigger sizes by increasing the speed and using the eccentric design of the device to reach out. So this is the orbital atherectomy device. You can see there is and part of the nose cone distal to the cutting surface, and then the bulge right here is the actual cutting surface that is going around in the lumen of the vessel. The other nice thing about eccentric cutting, rather than plugging the lesion like a rotablator does, is with orbital, with eccentric tissue ablation, you actually have perfusion around the device while you're working. So we've got good guide support, good reach, and you can see we're able to do quite a bit of tissue ablation throughout the course of this vessel. Straightening, now you can see how straight this mid-right actually is meant to be. And with sufficient ablation, my road test is to just see, can we dilate it to full size and or place a stent. So I'm not a big advocate of repeated intravascular imaging. I think for study protocols to learn things, I think for didactic and academic purposes, that's been a great teacher along the way. But clinically, if I can't get a full-size balloon fully expanded, I don't need an OCT or an IVUS to tell me that this lesion needs more work. And absolutely critically, we need to make that determination before we line the vessel with a stent. In this case, not only did the vessel dilate easily, but these are a series of 3.5, 38 millimeter Zions Alpine drug-eluting stents. And I take a picture at 8 atmospheres just to show how homogeneously, in fact, they can be deployed. This is the second one. And you can see it opens quite well, maybe a little dimple right here, and we'll solve that with high pressure dilatation and the proximal. And the final result. So I'm happy to say she did well. We didn't, of course, chase some of these larger than 4.0 areas in this very ectatic vessel. She did well and was home the next day. So to conclude, I think treatment strategies, from my perspective, you really need a clinical rationale, a means of detecting the level of calcium, and an approach to treating in a very systematic but not overextensive kind of way. The clinical rationale here, of course, is that calcific lesions provide any number of technical barriers that can result in suboptimal PCI, and that's associated with worse clinical outcomes. Whether we modify that sufficiently to change the clinical outcomes, we're currently enrolling in the Eclipse study. This is a prospective randomized trial between stenting and orbital atherectomy plus stenting and heavily calcified lesions. Enrollment was interrupted for about 3 months by the pandemic, but we are back enrolling again. And I think that'll give us a look at whether using more tools and creating better looking results translate to better clinical outcomes, but my prediction is it will. In detection of calcium, if you see it angiographically, it's very likely to be bad. But if you don't see it angiographically, particularly if you're working in my country with obese patients, calcium is frequently there. You just need intravascular imaging to actually see it if you don't see it with angiography. And in treatment, I think the two key aspects to treating calcific lesions are to debulk the plaque mass and to change the vessel compliance, to allow delivery of devices that are appropriate in size and length, and to be able to deploy them homogeneously so they can do their job the way they're designed to in creating a vessel lumen, in eluting drug locally to prevent restenosis. And along those lines, I find orbital atherectomy is far and away easiest to use. There's no nitrogen tank, it's an electric motor. You plug it in and you run it down. It allows controlled debulking. I can focus it on spots and use bidirectional to both change the bias in favor of what I want to accomplish. And it's ideal for radial. There's no upsizing of burrs or changing of burrs that require putting 7 or 8 French guide catheters in. It's all done through 6 French catheters. So again, it's really a very joyful morning for me to talk with my colleagues, friends, and teachers in India, and I'll surrender and stop here.
Thank you, sir. That was an elegant demonstration of orbital atherectomy. We'll now go to the second speaker, Dr. Balbir Singh on stent fractures, stent deformation, and stent compression and calcium.
So first, I would like to thank Dr. Silvanamani for having got me here, and also like to congratulate him for a wonderful meeting. Can you see my slides?
Sir, we see them.
Okay. So we are going to speak on stent deformation and stent fracture. So we know we want an ideal stent, we want a deliverable, deployable, and with a good long-term effect. But we also want that these shortcomings of deformation and fracture shouldn't happen. We want it to be fracture resistant. So how does this happen? So we want a good radial strength, we want a good longitudinal strength, we want flexibility. So if we want everything, then there is a trade-off. So the stents have hoops, which are these hoops, these two, and the connectors. Now, if you have more connectors, it becomes less deliverable. If you have more connectors, it becomes less deliverable. If you have less connectors, it is deliverable but loses the radial strength and is prone to deformation and fracture. So the metal alloy, strut thickness, and stent architecture all contribute to the radial strength. So what is stent longitudinal distortion? This is shortening or lengthening of the stent, and it can be caused by the guide catheter, post-dilatation balloon, intravascular ultrasound, and cause liminal malapposition stent deformities, and is one of the responsible factors for a MACE. Let's look at this example. This was a difficult lesion to cross with a stent. So there was a buddy wire on the side of it. Unfortunately, the buddy wire was not removed while the stent was deployed. And when the buddy wire was removed, you see this kind of stent deformation. So this indicates problems. This can sometimes lead to no other balloon crossing this lesion, and then you have to use many other techniques to get across it. Now, this is from Ormiston's data. These are the stent designs, and with a force applied of 0.5 Newton force, you can see how various stent designs behave differently. And it is basically responsibility of the connector to reduce this longitudinal deformity. And PROMUS was one of the biggest, PROMUS element was one of the biggest problems. And by adding more connectors on the proximal side, as suggested by Ormiston in 2014, they could get over some of these problems of deformities. Now, this is an elegant diagram to show what happens. So once you have the stent in, you have some malposition in the proximal part, you bring in the next balloon or the device or the intravascular ultrasound, you would hang to the edge of the stent and that deforms. So you try to keep pushing the device thinking that it's not going, so let me push a little harder, and it becomes more and more deformed. And this is where the problem actually comes. So how do we prevent? So understanding the stent that is being used, understanding the dilatation properties of that particular stent, and then applying very careful techniques, even balloon adhering after the stent has been deflated to the stent can also cause longitudinal deformity. What about stent structure? It has been recognized for many years, more than 10 years now, that it is associated with MACE and was very common with cipher. Very interestingly, there were most of the patients who had stent fractures were cipher. And the probability increases when there's long stents, overlapping stents, RCA, bend points, drug-eluting stents, and the stent design. This was the first example published in 2002 in the Images in Clinical Medicine. You see this is a stent in the SVG graft, and it is now into two halves. And these hinge points of the extra movement that happens on the stent in long term can lead to fractures. So they are associated with high rates of in-stent restenosis, TLRs, and also stent thrombosis. So these are the problems of stent fracture. So the stent fracture predisposing factor is the increasing length, vessel tortuosity, RCA location, SVG grafts, balloon overexpansion. So one should know the properties, how well can you expand with what balloon that you should use. Overlapping stents. Technical implications I've already discussed. The probable mechanism could be mechanical fatigue, hinge points during the vessel movement, increased stiffness. So the stents which are very conformable are better, less prone to stent fracture. Cipher was very unconformable stent, you know that, and maximum fractures happened with that. So management remains as to what the outcome is. Let's look at an example which was presented in 2019 TCT. This was a lesion. So the osteal lesion is the worst for stent fracture. 2011, a very good result. 2012, restenosis treated with a drug-eluting balloon. Comes back in 2013. Again, PCI is done, this time another stent, a biomatrix, but you look at a calcium nodule protruding into this vessel. And this was after the stent, previous stent restenosis. So MSA of 0.8, but this asymmetrical dilatation with a protruding stent. This patient came back in 2019, again with restenosis, and this time treated with a shock wave. But what you saw is this, this OCT image. The stent has been fractured at two places, this and this. Sometimes in neointimal hyperplasia also makes this area, doesn't show the stent margins, but if you look so the clinical outcomes of fractures are you see my slides?
We can't see the slide, Balbir, but we can see you now. You can
Okay,
go back and share slide, I believe.
Okay, I'll do that. Now can you see?
It's coming up.
Okay, so this depends from the degree of fracture. It has been divided into type 1 to type 4. So the time course, majority of the fractures happen within the 3 years. So the incidence maximum is 3 years, as you can see. And the patterns I already saw. It's the predictors I've already discussed, but it is associated with in-stent stenosis, occlusion, aneurysm, or definite stent thrombosis. Now, Bifurcation stenting has always been a problem because of the discrepancy in the distal sizing and the proximal sizing. So there is a territory which we know is malapposed. And when you try to treat this territory, a pot is generally required. And when doing this pot, you have to be very careful of the two problems that could happen. The potential oversizing the balloon and causing a stent deformity. So this chart is very important, and I guess everybody should know how this chart and what kind of crowns and connectors are available and what maximum size of balloon that can be used. So knowing the expansion properties of the stent is very important. So let's look at this example. There is a 3.5 vessel LED, 4.5 left main, and LCX is 3. Suppose you get a stent from left main to LCX, you take a 3 stent and then post-dilate with a 4.5 millimeter balloon as opposed to a 3.5 stent and post from LED. So what will happen at the ostium or circumflex? So why is ostium or circumflex so bad? Because you deform the stent when it is taking that bend at the ostium. So this part of the stent is overexpanded, the stent is deformed. So this part is barren, this part of the vessel will not have any stent, and this part has two crowded cells. So this is how these properties are important and we must know. Let's look at some of the overexpansion stent. So if you expand a stent to 6 millimeter, it will expand. Like for example, these stents have been expanded to 6 millimeter. They don't break. But what happens to the cells? They get really totally distorted. So the stent force and the longitudinal force are very important. So how do we diagnose on an intravascular ultrasound a longitudinal deformation or a deformation of stent? You see multiple layers of the stent, which can clearly tell you that this stent has been deformed. Now, this is what a fracture looks like on a microscopic appearance, that you see a connector going off here. You see not only the fracture, but the tumor has also gone away. So this is a test, a bend test to look at how fractures happen. And this has been seen with many stents. And Ornstone's bench test has told us that some of the stents have very good properties to prevent fractures. And let's look at a case. This was a 68-year-old gentleman who had a CTO of the LED and a tight diagonal disease. We also see calcium. So we see a calcium in the proximal part of this vessel. He also had a right coronary lesion. So this is the LED, which was crossed with a crusade, and we had now 2 wires, and we were able to cross the LED with difficulty, but we closed the diagonal. So we recrossed. Was brought in. Both were Rhine stents. So this is the lesion after balloon dilatation. The second stent is brought. Now, after the 2 stents were brought, we tried to do a pot. So I did do a pot with a 3.5 millimeter balloon there, and it won't go. And then I realized that the stent had deformed. I took a 1.5 millimeter balloon. It didn't cross. So we were in serious trouble. So finally got the guide liner into this part of the stent, got the balloon down, were able to do a final kissing and a final pot to get this result. But if you look carefully at this stent, this part of the stent shows deformation, because on stent boost, you would see this very clearly. See, this part of the stent looks different from this part. So there is some overlap of cells which causes the deformity. So one should be prepared to handle this situation. Once you get it, it's a difficult situation, but using guide liners, using all these techniques. So final kissing was done, and we got a good result in this lesion. This patient has done very well. So diagnosing by IVUS is looking at multiple layers of stent, means it is deformed. And this is from the Excel data that, let's look at this example. This is post-stent to LED LMCA. And this is the final picture. So this is the kissing balloon, and then this is after the kissing balloon. But what happens here? Look at this picture. You have multiple layers of stent coming in. After the kissing, you have deformed the stent. Not only have you deformed the stent, but also the area, the MSA has come down from 7.8 to 6.8, 6.4, which is a bad sign. So this is not a good sign. And in the Excel registry, Excel data, there was prevalence of stent deformation was 6.5% in the patients who underwent an intravascular ultrasound. And it's very, very bad to have this kind of deformation, particularly in left main. And ostium was the most prone because of the guide catheter. And people who had deformation had MACE. You can see the MACE is almost doubled at 3 years. Stent deformation is bad. Stent boost helps you to diagnose stent deformation, but not in all cases. So some kind of imaging is very useful. You may not always require another stent to correct deformation, but you require high pressure balloon dilatations. Make sure your lesion is good. Make sure there's no dissection in the proximal part, like we confirmed on OCT after we had corrected that deformation, that there was no proximal dissection, and we didn't need another stent in that case. So this is very important to understand. And thank you very much, Dr. V.T. Shah. I think I completed in time.
Excellent, Balbir. I think we will have some interaction now, both with Dr. Michelle and Dr. Balbir Singh. So let me first go to Dr. Michelle Krukov and ask him certain questions, since there are two technologies which we don't have in India and which you in USA have for calcium. One is the orbital and the other is the laser. We still don't have, and maybe in the future, in the next 6 months to 1 year, hopefully we should get it. So therefore,
Dr. V.T. Shah, laser will be available next month.
Yeah, hopefully, yeah. They have been saying this, but let us hope if it is available sooner the better. So we would like to get some experience from you, and from the case which you showed, certain questions did arise for orbital atherectomy. And those questions are that, do you think that with orbital, there is less of burr trapping? It has an advantage in tortuous lesions, and the slow flow incidence is less. Is it so?
So I'll go backwards and you can remind me if I forget, but the slow flow, I think definitely is yes. There's less slow flow, and for several reasons. One, part of the technique, you know, it's ironic. I go back, I'm an old guy, so I go back to when rotablator first came forward. One of the key teaching principles that Maurice Bookbinder did in the early instruction courses was to emphasize going slowly. And that's been lost. Rotablator around the world now, you see people so part of that, I think rotablator slow flow could be less if operators would just slow down again. But the orbital atherectomy requires you to go slow, because literally that's how the device more efficiently achieves its mechanism of cutting. Secondly, as I mentioned, because it's eccentric rather than concentric, I think there's just more flow during the procedure. And thirdly, in both roto and orbital, I put vasodilators in the solution that flushes through the device, and the orbital device flushes a higher volume of solution. So again, all of these things I think go together to dilate the microvasculature, to make sure that the operator doesn't start going super fast, and also to encourage perfusion during the procedure itself. In terms of tortuosity, I think that's something to be very careful about in any kind of atherectomy device. If the vessel is truly tortuous, then you really have to be careful. You can create very bad dissections or perforations. On the other hand, as I showed, I think when you have angulation, and it may be a pseudo tortuosity, it's really the plaque that makes the lumen look tortuous, but the vessel is really not so tortuous. You can get a good feel for that by, again, not pushing through the lesion, but getting through the lesion and pulling back. And the bidirectional cutting, when you pull back, the shaft of the device creates a straightening so that what you're ablating is not going to be a pinched vessel. It'll be whatever plaque is there. So the ability to work from beyond pulling back as well as forward and back is not just an efficiency, but I think adds safety to the range of control you have of how to use the device. And I apologize, there's a third.
Bird trapping, bird trapping
Trapping?
of the burr.
But yes. Yeah, so again, I definitely think that is much less with orbital because you have cutting surface both ways. And I think that's with roto, and I think we learned this when we first had the JJIS stent jail, and Auth showed that you could actually cut through metal, that we unjailed some stents by pushing a little too hard, too fast with a roto, and we could get it through the cell. But then we had a real problem because it was not happy to come back, and there's no cutting surface on the back edge. So I think, again, orbital has cutting surface on the outside. It's not a front edge, not back edge, or, you know. So I think the entrapment feature is something you can actually cut your way out of. You just have to be patient.
Yeah, and the last question is, does orbital have an advantage in calcified nodule versus rota?
So I do think there are some scenarios where a 125 roto burr will go through something that an orbital may not. And the non-crossing feature, I think, is probably fractionally more with an orbital than with rota. That being said, if you pay attention to two features, I've actually been surprised. I thought this difference would be much greater, but including the right coronary artery lesion I showed, is a very tick-tight lesion. You could feel the 14,000th wire scraping going through that. That the glide assist that allows the orbital to rotate will rotate the nose, not the cutting surface, but the nose through lesions that are completely undilatable with a 1.0 balloon, and work your way through it and cut through it. So I do think that in the design, front cutting, rota has a unique position, but it is a much smaller fraction of cases than I thought, because the orbital, one thing about orbital, and I'll finish, that you must pay attention to, though, is guide catheter support is very important for the orbital. And rota, as we all know, rota can be very efficient even if the guide catheter is out in the aorta.
Yeah, Dr. Sujata and Dr. Reddy, please.
Yeah, Vitisha sir, we have on that lot of questions which has come. If you permit, we'll just project it there, and we'll ask our expert panel, Kirti, Reddy sir and Sujata madam, probably they can go through the questions and answer.
Yeah, please go ahead.
I think you can see the questions now, no? So you can just read it and then probably you can take one by one, sir.
Yeah, Dr. Sujata, please go ahead. Unmute yourself. Unmute yourself.
I think Dr. Reddy would be best to answer. Can you share some advantages of laser for which type of calcium, as we don't have any experience in India with laser?
Yeah.
Dr. Michelle, I think your views on that.
I think Vivek should go ahead. Dr. Reddy.
Yeah, laser, we don't have any experience, but I understand, of course, if there's a balloon non-crossability, that is one technology which might help. Well, you should tell us something about that.
Yeah, but probably I think when we can't cross with a wire, I think laser comes there. Like, for example, if you can cross a wire, if you are unable to take the balloon, probably we'll have to take a rota. And there are some cases where you just cannot cross the wire. Probably there laser will be useful. And anyhow, we don't have a laser here, and it's only a theoretical knowledge. Probably Krukov sir might be having some experience. He can put a light into this laser, where he exactly uses it, how he uses it.
Yeah, so in fact, laser is a fascinating technology. You all probably know there was a laser wire which was developed, and I was on the FDA advisory panel that reviewed that wire. And for settings like Dr. Selvamani you're referring to, for when a wire won't cross, can use a laser wire to find that, really as a CTO type of question. And there, the value of the laser wire, unfortunately, was balanced against the perforation rate of the laser wire. So that's the challenge with laser, is how much is enough and how to best direct it. Now with eccentric cutting, I think the ability to, for instance, focus on a nodule or something that, if you can get an OCT down and see directionally where it is, that becomes very valuable. But a lot of these lesions, you can't cross them with a wire or a 1.0 balloon. You can't cross them with an OCT. So I think laser is a very powerful tool. I think understanding its orientation, circumferential laser, I think is a little less valuable in my experience than eccentric laser, which you can direct more, and direct cutting to the bulkier side of a lesion. And obviously laser has also led us to technologies like shockwave technology, where we're looking at the explosiveness of contrast in laser as being able to fracture plaque. And I think, again, we have a lot to learn about finding the sweet spot. So we're fracturing plaque, not blowing up arteries. But I think it's a technology that all of us are very interested in, and it's very different than atherectomy mechanistically.
Yeah. So what is the preferred timeline for DAPT after treating calcified lesion? Is it different from routine complex procedure, or something the same like a routine procedure there? Anyone can take it.
Sir, it depends on the clinical situation rather than there is calcium or not.
Calcium.
If I'm not right, Dr. Kirti, it depends upon whether it is an ACS or whether it is stable ischemic heart disease rather than the calcium.
And more upon the end result of your procedure. If the end result is not good, you are leaving an unexpanded stent, then I think you will have to give strong drugs till you take the patient back and give a perfect result.
Yeah, I would agree very much with Dr. Shah that if for any reason, and again, these can be very complex, the final result is in any way suboptimal, then I think more aggressive adjunctive medical therapy is just protective for the patient.
Next, I think that goes to Dr. Balbir. There's a lot of difficulty in tracking the stent in the calcified lesion. And is there any difference with thin stent support or radial stent? That is what they have asked there.
Okay, so first thing is that majority of the stents now available are thin struts. So some people have gone down to 64. So the fact is that when one stent has been compared to another stent, most of the studies have excluded heavy calcific lesions. So they have taken simple lesions. So how will one behave against another one in a calcific lesion is very difficult to assess. But I would like to choose a stent which has high radial strength. Yes, it is true, a thinner strut is more flexible, may go through it. But the fact also remains is that if there is calcium and your stent is not crossing, think of creating a better bed, because you may even get through it, but you will end up in an underexpanded stent. And it is very important that if the stent is not tracking very smoothly in a calcific lesion, your bed is not well prepared to handle that stent. So this actually may be a boon, that you get an answer that now you have to prepare your bed better so that your stent expands. Leaving an unexpanded stent is dangerous. But I would clearly like to use a stent with good radial strength to handle calcific lesions, because you will need high pressure balloon dilatations. You may fracture these stent struts. You may damage the polymer when you go to very high pressures. So a good radial strength stent is important. And use of guideliners or other things may help, but preparing the bed is the most crucial thing for the stent to reach. So don't rely on thin struts to reach you there. Rely on preparing the bed to help you go there.
Kirti sir, do you have any suggestions, like in which type of stents we have high incidence of LSD? Is there any specific reason, or what is your experience in this stent deformation, longitudinal stent deformation?
So I think as far as I'm concerned, there are two types of stent deformation. One is which is the most frequent, is the proximal end of the stent.
Kirti, a bit louder. Kirti, a bit louder. We can't hear you.
Can you hear me now?
Yeah, that's better.
Better.
Okay. So essentially, I see two types of stent deformations. One along the longitudinal axis of the stent, and that's at the proximal end almost always from a guide catheter, or in the body of the stent, or at the distal end. The deformation is because a wire has got stuck, or an IVUS catheter got stuck into a strut and you pulled it out, or things like that. And stent deformation is probably a function of malapposition, because opposed stents are very difficult to deform. That's one. The second is the transsectional, like in a transverse plane, in a cross section stent deformation, where all the struts are aligned on one side and the strut opens up very asymmetrically. I think both are issues, and you see a lot of plaque prolapse in those cases. There's just another question. I think I completely agree with Balbir when he says that lesion preparation is the key, because if you prepare your lesion well and you've got an expansion with your balloons and your preparatory material well, then we have used all kinds of all the new generation stents. We've not seen any difference. And even if there's a small amount of recoil with a certain stent, I would love to see data which shows that changes outcome really in those patients. Most of us do angios immediately, but if you were to wait 10 or 20 minutes and then do an IVUS run, you probably start seeing recoils in almost every stent. So lesion preparation is a key, and unexpanded stents is a function of a poorly prepared lesion or a stubborn lesion sometimes.
Fine. So we'll take the last question. So far, we don't have strong data on OCT in calcium. So what is your viewpoint regarding this OCT imaging in calcium? Dr. Krukov, your point of view.
Well, I agree, number one, and I think the reason is, again, obvious to anybody as an operator who tries it, is that on a lot of these nasty lesions where it's hard to get a 1.5 balloon through it, you're not going to get an OCT catheter through it. So sometimes the strategy is to try and mildly dilate, gently dilate with a very small balloon, just to make enough room to image. I will give a different kind of credit where credit's due, is to our colleagues in Japan, who have with the launch of the orbital atherectomy device, have been doing sequential imaging to understand the means of debulking, the stages of debulking with the orbital atherectomy. And I think that has taught us a lot about the degree of lesion preparation, which I think, as Dr. Singh was saying and was just amplified, is the critical the critical part of this is lesion preparation. So I think, again, for that kind of learning purpose, to understand and actually see with OCT after 4 runs, after 8 runs, after 12 runs, the actual progression of how much you're debulking, to me, that's also hopefully going to guide us towards, and at what point do you get too far and potentially start to risk, with lesion preparation, a greater likelihood of lesion perforation. So I think OCT imaging, the resolution, it's so much more facile to use now. The automated tools that are embedded within it has advanced so many things that we are learning about. But one of the hardest is still what a de novo heavily calcified lesion looks like when it involves a lumen so small that you can't get a device down through.
Dr. Selvamani, if you permit me one last question to Dr.
Sure.
Balbir.
Sure, sir. Sure. Finish it off.
Dr. Balbir, can you stress the importance of stent boost in detection of longitudinal stent deformation, strut fractures, and so on, especially where imaging is not done or imaging catheter cannot go through?
Right. So the first thing that happens when longitudinal deformity happens is that your hardware doesn't go in so easily. So the first attempt when your balloon is not crossing the stent is not to push more, is to pull it out and take a new balloon, smaller size, because the more you push, the more deformity happens. And stent boost is a wonderful tool because imaging will detect it at the last. Imaging cannot detect it at the right beginning. So when you are there with the balloon and you have the slightest of friction of getting the balloon in, you are in trouble. Don't do it. And the second thing that I want to say is that when you do in a tapered vessel, your proximal part of the stent is malapposed. Use a new balloon. Don't take a reused balloon because you will be in trouble. And third is when, as Kirti said, the guide catheter hitting a left main ostium is one of the major problems of stent deformity.
Fine. So that's learned from the master's session. And I am sure that each of you had a great learning experience. And it was really good learning regarding the treatment strategies for PCI and probably evaluation of calcium also. It was nicely explained by both the masters. And special thanks to our international faculty, Dr. Krukov, who, in spite of change in his time zone, took his effort to join us. And we really thank you for that. And I also came to know that you visit Puttaparthi here for Sai Baba, and probably next time when you come here, we should definitely meet and go together